So are we ready to go?
Yeah.
Okay. Right. Welcome everybody to the joint committee meeting of West Lancashire and Southport and Formby CCGs. I'll first of all ask everybody to introduce themselves. I'll start with myself. My name is Helen Nichols. I'm a lay member for Southport and Formby CCG. I'll go to Dr. Bizaria.
Hello, Dr. Bizaria, GP in Skelmersdale in West Lancashire and on the CCG for West Lancashire.
Fiona.
I'm Fiona Taylor. I'm the Accountable Officer of Southport and Formby CCG.
Greg.
Hello, Craig Mitten, lay member, West Lancs CCG.
Jackie.
Hi, Jackie Moran. I'm Director of Integration and Transformation at West Lancs CCG, and I'm in attendance today covering for Paul Kingan, who's away on his annual leave.
Thank you. Susie.
Hi, I'm Susie Ning. I'm the Programme Director for Shape Care Together.
Dr. Cordwell.
Hi, Rob Cordwell, GP in Southport, Chair of Southport and Formby CCG and Clinical Director of Southport and Formby PCN.
Terry.
Terry Stapley, Corporate Business Manager for Southport and Formby CCG and minute taker today.
Thank you all very much. And we've had apologies from Paul Kingan, and Jackie's standing in for him, as she said, Dr. Gregory, and Ruth Fairhurst. Okay, otherwise we have got the attendees that we're expecting. We're just checking on Dr. Metzmasher. Okay, so thank you very much, everybody. Declarations of interest. We've got a standing declaration from Greg in respect of his voluntary services work, which is a standard item on all of our minutes. Is there anything else that anybody wants to declare? Okay. That's fine. So we'll move on to the minutes of our last meeting, which was on the 25th of March. Has anybody got any issues of accuracy on page, this is of the pack, page 2, page 3, page 4, page 5, page 6? Okay. So we'll take those as an accurate record, and the only action was in respect of inputting from the joint committee to the programme board, and that has been completed since our last meeting. Okay, so we'll move on to our first substantive item, which is the Shaping Care Together overview, which is going to be covered by Fiona Taylor and Susie Ning. I'll hand over to you, Fiona.
Thank you, Chair. Susie's very kindly going to share a screen. So just to remind Joint Committee about Shaping Care Together before Susie goes into the detail in the highlight report. Next slide, Susie. Thank you. So the programme team led by Susie in partnership with CCGs and the colleagues, particularly in the Southport and Ormskirk Trust, have been working on the development of a vision. This vision is on this slide. Obviously, it very much dovetails into both West Lancashire's strategic plans and those of Sefton's, and bearing in mind the imminent changes with CCG landscape, that of both Lancashire and South Cumbria ICS and Cheshire and Merseyside ICS. The main focus to draw out really on the next slide, please, Susie, is why are we doing this? So this is about making sure that the hospital services are there when people need them. So getting the right care at the right time in the right place. Obviously, what we're about is making sure that all our services are safe and sustainable and delivered with a high quality aspect. And what we are trying to do with this programme, Shaping Care Together, is make sure there is the joining up of care out of hospital and that the hospital provides. But it is multifaceted in terms of the complexity of making sure that care out in our community settings with general practice and community voluntary faith sector is a very much an answer to some of the issues that we've got within the context of the hospital. So what we're trying to do with this programme, Shaping Care Together, to remind us all, is promote the timely discharge of patients out of hospitals when they don't need to be in a hospital bed. That's very important in terms of recent times with the pandemic. Making sure that we've got the ability to recruit high calibre staff and retain them. And we know we've got challenges on our patch with that. Making sure that the services are not just responsive for the needs of today, but the demographic changes that we are expecting in the next sort of 5 to 10 years and beyond, and making sure that we've got our care across both health and social, community and hospital very much joined up in the sense of planned, so as we understand the impact of one element of the system on another, and not least around that we've got the best clinicians that can support the delivery of that care and other professionals allied to clinical care, some of our domiciliary care support. Financial pressures are obviously still underlying within the context of the Southport and Ormskirk Trust working on 2 separate sites. So obviously all of this firstly is about utilisation of resource, making sure we're using the right people in the right place and getting good people, and making sure that we are meeting need and reducing some of our health inequalities and improving health outcomes, and also making sure we make best use of taxpayers' money. Just a note here that the interdependency across the system, so while this is very much focused on the work that Southport and Ormskirk deliver, it is important that partners that are working around the organisation are heavily involved, and I'm sure Susie will draw some of that out in a presentation. And we know recently that there's been an announcement this week with the movement of the chief exec, who secured another job, which is absolutely fantastic for Trish Armstrong-Chiles. We will miss her because she's been an absolute stalwart in terms of supporting the delivery of Shaping Care Together. But we're very clear as CCGs in our responsible role on the Joint Committee that the change in personnel is not about derailing the programme of work. So we will continue to drive Shaping Care Together because we want to do all the things that I've just described. So I'm going to pass over to Susie to continue, Chair, if that's okay.
Thanks very much, Fiona.
Thank you, Fiona. Thank you, Chair. So just in terms of what we're focusing on within the programme, we've identified some really key areas to focus on. Those include care for the frail and elderly, those who need urgent or emergency treatment, care for children, maternity care for pregnant women and their newborn babies. We're also looking at care relating to women's reproductive and urinary systems, or gynecology, sexual health care, as well as planned care. And those are things including things like outpatient appointments or planned kind of surgery, for example. So for the conversations we're having with both the public, with our patients and staff, are really looking at those particular areas and how do we improve them, what's working well, how do we want to move things forward. Our approach for that engagement is on a trajectory that is in 4 stages. So we've just completed our stage 1, which is how do we explore what the status quo is. We've been seeking views through our online questionnaire around what's good, what's bad, what needs improving, what are the negative, how do we avoid any negative impacts, and what also are measurable solutions. And also explore how well our duties are met within the status quo. So all the kind of statutory requirements we need to make as CCGs and also as a trust who provides those services, how do we ensure we're really robustly engaging with our public and with our patients and staff to really get those views, and so we're really clear what the issues are and how we want to move forward. We're currently in stage 2, so we're just developing what our solutions might look like. So again, engaging with those people, with our relevant stakeholders, as well as we've got political, both local and national politicians involved in terms of the conversations we're having, but also, as Fiona talked through, the wider NHS and care setting in terms of how do we develop those solutions, building on what we've learned from the status quo. Moving forward, we'll then develop some robust solutions. So this is where we'll start developing our really interesting options about how we want to move things forward. And this is based on a model of care that we're working with our clinical and care colleagues, that we're testing out with our patients and public and staff, and then working through how do we develop a shortlist that we'd want to robustly appraise, which leads us into stage 4, which is our options appraisal process. And that will then, working with a wider group of people who will look at how we've developed those options, the evidence around each of them that show the benefits and risks, and then what would we want to take forward into public consultation. So it's a structured approach we're taking, but we're trying to take a really holistic approach in how we get this information, how we test this out, how we get really robust challenge into our process as well as we go through this journey. In terms of the programme itself, there's 3 main structures, 3 main programmes, work streams sitting under that programme. So fundamental to what we're trying to do, we're developing a Shaping Care Together clinical and care strategy with underpinning model of care. So this will describe how health and care will look in the future for our populations across Southport, Formby and West Lancashire. This is led by our clinical and care leaders, but also through that engagement process that I've just described. And it will underpin those models of care for those key areas of focus that I described earlier. We'll have a system-wide quality impact assessment. So anything that comes through in terms of what new models of care would look like for the future will be robustly assessed by our clinical and care leaders and experts to make sure that they have a positive impact and benefits to our patient and populations, as well as to those staff that will be delivering them. We need some technical things within that process as well. So we've developed a hurdle criteria. So this is the first stage that will take a long list of those solutions that we're developing and then translate them into a shorter list that we can do some really robust modelling and evidence gathering, which will then lead into that options appraisal. And that options appraisal process will use the evaluation criteria, which is getting developed with our key stakeholders, that will go into the real detail of how we can use a robust analysis of the benefits and risks each of those options could lead to, which will end up with our small list of preferred options we'd want to formally consult with our public on. We're also bringing in some external scrutiny as well through what are called the clinical senates. These are NHS institutes of a group of clinicians outside of our area that will come in and really robustly scrutinise the models of care we've developed, the strategy and our pathways that the patients should follow over the next few weeks and months. Another core component, which I've described in high level, is the comms and engagement. So it's using public, patient and staff experiences and understanding and concerns and positive feelings about health and care services. It's also really maximising our community assets, and we've been working really closely with both CVSs across West Lancashire and Sefton to really make sure we're tapping into those groups that will be affected by any of those services that we want to make sure are not negatively impacted on any suggestions or options we put forward. We're having some oversight through the Health Watch that make sure that everything we're doing has a real focus on that patient perspective. Reputational management is really important in the sense that we want to bring along with us our local councillors and our MPs as well in the conversation, and they are a key stakeholder in everything we're trying to do to make sure that everyone's in line with what we're doing and how we're proposing to move things forward. Equalities is a really fundamental part of it, so we want to make sure that from an equalities in terms of our statutory duties perspective, that we understand the impact of our current service provision on the equalities agenda, but also again with those options as they move forward, what impact would that have on our equalities, but also health inequalities, what health inequalities are in existence with our current services and how do we reduce them as much as possible with the options that we're going to put forward. And then there's the options development and appraisal plan, which I've just talked through. And ultimately, this will lead to a public consultation. So part of the work we're doing at the moment is making sure we have a really robust consultation plan to give people a really good opportunity to look at what we're suggesting, what we're putting forward as a system, and give their feedback into that process through a formal public consultation. And then the final piece of the programme, the final work stream is the technical piece. We have to produce a suite of evidence that will go to NHS England, NHS Improvement, to look at what we've done in terms of the options process, what evidence we've got in terms of those benefits and risks for each of those options that we want to put forward. And we're looking at things like demands and activity and capacity issues, looking at estates opportunities, workforce challenges and opportunities, looking at the transport as well. Transport's a really interesting one because we want to make sure, again, that the health inequalities are created by any potential movement of services that would be put forward as part of that public consultation. So we're bringing in a whole body of evidence around that. Digital as well, obviously with the last 16 to 18 months with the pandemic, digital's played a really big part. What would that look like in the future? How do we maximise that? But recognising that we don't want to disadvantage groups of people that wouldn't have that digital access that majority of the population do. So again, we're working through, you know, what the opportunities digital can bring. Obviously, the financial sustainability will play into that, and we need to make sure that everything we do is within our financial envelope and is affordable. This all produces a pre-consultation business case, or a PCBC, and an associated body of evidence that would address any, I've abbreviated them here, but they're key lines of inquiry that would come out of that stage 2 assurance process. We want to make sure we have impact assessments around this as well. So everything we're suggesting will understand the impact that will have on other providers across the area. Also, from a sustainability and environmental sustainability perspective, you know, what impact any service reconfiguration proposals will come through will have. And also with the digital aspect and information flows that might potentially change as those options, we'll have a really clear understanding of what, from a data privacy perspective, what impact that might have. So, Chair, that's the end of the general overview of the Shaping Care Together part of my presentation. Thank you.
Thanks very much, Susie. Do you want to continue straight on to the highlight report? And then after we've had your highlight report, we'll take any questions or comments that anybody wants to make.
No problem. Okay, I'll just bring my screen back up again. I was a bit premature in closing that, then I apologise.
Sorry.
Okay, thank you. So just in terms of where we're up to, the programme's been running now probably since September last year. So in terms of that engagement and communication, we've developed an issues paper that's brought through all that data, all that intelligence we've got from that status quo part of our engagement. We've developed an engagement report that's given us really interesting information about who's been able to access our online survey. We've held several focus groups, so all the data that's coming in from those. So that engagement report and some of the key themes that relate to those areas that we're focusing on has come forward from that. So that's been really a very useful exercise. It isn't closed down. We're continuing engagement throughout this whole process. So as more and more people become aware of Shaping Care Together, they've still got an opportunity to fill that questionnaire in to get in touch and become part of those focus groups as well. We're looking at doing formal briefings with our local councillors to bring them up to speed with our process as well as with our MPs. And we've developed a formal Shaping Care Together newsletter, which we've had our first issue sent out, and we'll do subsequent issues as we move forward with our stakeholders, which range right from the public and patients through to different providers, different interested parties. As I said, we've done some focus groups and extend our thanks to both CVSs across Sefton and West Lancashire for supporting us and helping us get onto the agenda for those community teams out there that are really important to understand what their perspective is. And we're also developing what we're calling an engagement process advisory group, which will be a mixture of public, patients and staff to look at how we're engaging with our communities, how we're engaging widely, to make sure that the process is robust and we are maximising as much opportunities to do that engagement as possible. As part of that discussion as well, some of the information that's coming out from us is helping us to develop that long list of options. So that work is ongoing at the moment. So we'll start, everything's on the table in terms of that long list. So we're bringing that through. We did at the time of writing this report have some drop-in sessions for our local councillors in place. They've had to be delayed slightly due to availability, but that will be they will be put back into the diary as soon as possible. In terms of our clinical care engagement and leadership, we have developed draft models of care now for all those 7 areas, which looks, which have got refreshed graphics that just on a page you can see what those models would look like for the future. We've developed that hurdle criteria that will help us get from our long list to a shorter list. And we're looking at also drafting our evaluation criteria, which will help with the options appraisal piece. The system quality impact assessment process has been agreed, so we've got that in place ready for when those models of care can be taken through them. And we've also engaged with our North West Clinical Senate, who will come in at the end of this process and assess our development of our clinical models of care and assess our approach to make sure it is robust, and that will form part of our stage 2 assurance process. But we've also asked Yorkshire and Humber Clinical Senate to come in the middle of the process to kind of check our homework, make sure that we're on the right track, that we're thinking of the right things, that we're aligning our models of care with best practice. So we're trying to get as much robust external clinical scrutiny into the process as possible. So that's all in train. In terms of the business case, we've completed on the whole our baseline work. We've got a baseline assessment now of the workforce challenges within the trust, of the digital maturity within the trust, as well as out in both places across Sefton and West Lancashire. And we've also completed our travel assessment and the activity in terms of what the current demand for services looks like, both from who's currently accessing those hospital services, but also for the populations of Southport, Formby and West Lancashire, where they are also currently accessing acute services, which could be slightly different. So we've brought all that together. We've also brought in the CSU to help us with some of that activity modelling and financial modelling, and they're going to also help us author the technical document of the business case and strategy. Our estates baseline is near completion. It was due for debt today, so we're hoping to receive that very soon, which will give a real in-depth look of the state of estates within both Southport Hospital and Ormskirk Hospital, but they've also done an understanding of what's out there in the community, what are the available estate out in the community, if we want to think about how we want to move services closer to home for people. In terms of the fragile services work that's undergoing within the trust, we are aligned really closely with that piece of work as well. So we're building on any kind of operational work that's happening within the trust with the work of Shaping Care Together, and likewise they're developing their operational improvement work in the context of Shaping Care Together. So we're really embedded within the operational work within the trust. We've got a memorandum of understanding as well set up between the 3 directors of finance, chief financial officers across the 2 CCGs and the trust that kind of have that principle of working together and sharing data. So that's been a really positive move forward. And all of our contracts that we hold with external suppliers producing this work, we've had contract review meetings this past month as well to make sure that everything's on track and we're getting the best value for money from that process. We have a CST budget, which has been ratified with the CCGs, leads within Southport and Formby who hold the budget, so that we are trying, again, showing the value for money, that we're spending the budget appropriately and effectively to get the best results moving forward. In terms of the next period of time, we are looking to continue with our focus groups, continue moving those out throughout July and August. We're also undertaking a full equality and health inequalities impact assessment from the stage 1 work and moving into the stage 2 work. And we're also obviously continuing with our political briefings and making recommendations for a joint OSC as well, which will hold the whole programme to account as we move forward into the stage 2 assurance. We will have those drop-in sessions booked in for our local councillors, and the engagement process advisory group will be fully established as well within this next reporting period. Our models of care will all be refreshed in terms of the clinical elements of the work stream, and we will have a 1 model of care that we can talk to, and that will all be drafted ready for the next stage of work. And we all have started work on that strategy that pulls this all together in a really good narrative to move forward. We will look to apply the hurdle criteria to the emerging long list as well, so we can start thinking about how we can take forward that modelling work. And we've got a round 4 of clinical workshops happening in August, where our clinical and care leader colleagues will be able to come in, looking at those models of care and then testing them out with patient pathways. So we're looking at specific patient scenarios to make sure that we're really kind of focusing on the patient journey that might occur through these models of care moving forward, to test out that they are fit for purpose. And that will be the basis then of the patient benefits work we're going to start using, working on moving forward. In terms of the business case, we will have described our modelling approach for the options moving forward, some technical stuff there in terms of moving that forward. We will have our baselines all ratified and pulled together, so we'll have one version of the truth, which will feed both into the work we're doing, but also really help with the operational side within the hospitals. And we'll have started thinking about how we do that future options modelling as though that shorter list starts coming through. In terms of the kind of technical piece of moving into that stage 2 assurance, we're also establishing a data room. So we'll hold that kind of one version of the truth on a centrally stored area that is able to be allocated to all the key stakeholders that would need access to that moving forward. So just making sure we've got a really robust way of holding data and sharing data. So again, that one version of the truth is really, really important. And we'll have a review of the budget as well to make sure that we still continue to get value for money from the money that's been invested. Just in terms of our key issues, so the ongoing issue that we have across all of the work streams that we're working through is the challenge to engage with a clinical body of people who are absolutely flat out with their day job, or exhausted after the last 16 to 18 months. And trying to work with them to help develop what the future would look like. We've tried different ways to mitigate that, because recognising trying to bring clinicians from the front line into workshops is really challenging and very difficult to do consistently. So we've developed an online collaboration platform where we can put the models care on, and we can actively look at them and challenge them through the keyboard, but also thinking about linking in with existing groups out in the system, so we can start talking to people a bit more and getting that challenge back in. And also using that ambassadorship role within each of the groups that we've got. So we've got a clinical and care congress, we've got a steering group. It's how do we get people who are attending these meetings to really talk about shaping care together and share those opportunities to engage. What we absolutely must have as an end result of all of this activity are models of care that people recognise and people own, people feel like they've had an opportunity to develop and challenge and shape as we move that forward. So that's a key component of this, but it needs to be recognised at Joint Committee that it is an ongoing challenge for a variety of very, very good reasons, but we will continue to try and mitigate against that. And I suppose the final slide, just as I move past the highlight report, is just to share with you what the hurdle criteria has been developed and what that looks like to mainly get some approval from yourselves as a joint committee. So again, the purpose of the hurdle criteria is to take the long list, the wish list of what options look like for the future, and then apply a binary go or no go to those options if they fit within each of these criteria. So the first one is around clinical sustainability. So whatever option we're looking at, it must enable the delivery of the Shaping Care Together overall model of care. It must be able to maintain or improve access to services, so specialist services. It must also have that strategic fit and support the agreed plans of both the emerging ICPs, the places within West Lancs and Sefton, but also within the ICSs, recognising we've got Lancashire South Cumbria ICS as well as Cheshire and Merseyside ICS, and it must support that principle of improving population health. Financial affordability, none of the options that come out should not require significant capital investment. We've put an example here of a new hospital site because we are not part of the new hospitals programme. We are looking at how we can best utilise our existing footprints. And then finally, the options must be deliverable. We need to make sure we can actually implement them. They must be realistic. So I wanted to kind of test the hurdle criteria with yourselves as joint committee today, but give you the recognition that this has gone through our clinical steering group and our clinical and care congress, as well as our programme board, but it needs to come to joint committee for final review. Okay, and with that, I shall stop presenting. Thank you very much.
Thank you very much indeed, Susie, for that comprehensive presentation. Right, so I'll open it up for any comments or queries that anybody's got. Rob, you've got your hand up first.
Yeah, but just a quick query. I think we may have touched on this at the steering group, but with the hurdle criteria, the one that says does not require significant capital investment, what do we mean by significant? It can mean different things to different people, is it? Do we need to kind of put a number on it, or do we need to say, more than we've got, which isn't very much, or it could just be interpreted in different ways? It's going to need some capital investment, presumably, but is it clear enough, or do we leave it as it is to give us scope to kind of make that judgment later?
I think the example there is the key piece. So if one of the options is there is as a new hospital site, it wouldn't pass that hurdle criteria. I think again, it's the way the hurdle criteria will be applied will be clinically led. So that's where the discussions can be had. So if we don't know what capital is available at the moment, we do know we need capital investment. Part of the PCBC approach will likely include a capital investment approach as well. But just to get us through this first stage, if a lot of the options talk about a new hospital, we just wouldn't be able to take it through to the next stage of modelling.
Okay, thank you.
Okay, Fiona. You're on mute, Fiona.
There were just a couple of things, Helen, Chair, that struck me. One was around outcome benefits. So, what's it going to deliver that might be different? And the other was around sustainability. So I don't mean financial or clinical. I mean the model of care. And maybe that is clinical sustainability, and I'm probably not articulating myself in terms of what I'm trying to say here. So I need to just have a think about how easy it will, given the challenges and changes in demography and everything. So I'm not particularly thinking about the clinical model itself, but more the workforce dynamic. And maybe you've scooped that up into the clinical sustainability. Do you understand what I'm trying to get at?
Yeah.
So there's a model of care saying you deliver a pathway like this, but then have we got the people to deliver the pathway of care, and have you wrapped that all together?
Absolutely, and I think it's a really important point. So the hurdle criteria won't have that level of detail. So the purpose of the hurdle criteria is just to go through the long list. The evaluation criteria absolutely will have that nuanced detail in, but just to give you the assurance that the modelling we're doing will have the benefits of the impact it'll have on workforce, the impact it'll have on the state, etc., etc. But it's the evaluation criteria when we've got the evidence to actually look at that'll make the shorter list.
That's really helpful to clarify. Thank you, Susie.
Okay, any other comments or questions? Jackie.
Helen, I hope you're okay that I ask a question. I know I'm only here in attendance for Paul. But I suppose it was a similar vein, Susie, if I could, because you talked about doing the QIA, the quality impact assessment, and I think you also talked about the equality and health inequalities impact assessments. And I suppose I was just thinking about how they're different maybe to the hurdle criteria you've talked about and to the evaluation criteria, and at what point we think about, because I think you said we want to make sure there's no negative impact for our residents, but in fact some of the options that will be put forward will have a negative impact, won't it? So I suppose in doing these impact assessments, it's to understand, isn't it, whether they do have a negative or a positive impact for people, and at what point do we consider that in this process?
Okay, thank you, Jackie. So in response to that, so in terms of the quality impact assessment, that will be looking at the overarching model of care, irrespective of where that's delivered. So the overarching model of care will look at it to make sure that it is safe, that it delivers high quality, improves outcome as a general principle. As we start looking at the options, we'll talk about how that model of care will be delivered. That's where you'll think about the impact it'll have on equalities in terms of access and outcomes and health inequalities, but also, your travel impact assessment will play into that, your provider impact, there's quite a lot of impact assessments that will come into that. So in between the hurdle criteria being undertaken and we've got a shorter list, a whole host of modelling then around each of the options that are left on the table will be undertaken. So when we get to the options appraisal piece, each option that's on the table to be appraised will have an impact on the workforce, travel, health inequalities, equalities. So you can see the benefits and risks of all those options.
That's lovely. I understand that now. Thank you, Susie.
Okay, Thank you. Greg.
Yes, thank you, Chair. Thank you for the presentation, Susie. In preparing for this meeting, I was obviously particularly concerned about engagement and participation. And I think you've answered the questions that I'd written down. But in terms of the engagement, I just want to be sure that I picked up that actually that is an ongoing situation, because I relate it to the really important point you made about GPs, clinical staff, and in fact all staff within the NHS system, including care, that have been so impacted by COVID and who are all absolutely exhausted. And same is true of the community in their struggles to cope with the pandemic. And so we did discuss previously how receptive people could be beyond the need to cope with their immediate needs and deal with the impact that they're experiencing. So that sounds really positive to me, that as we hopefully go into recovery, that I think the community will be able to engage more. So it seems from what you're saying that we're ensuring that process is still an open door process and will continue. And then I just wanted to check, going on to the engagement process advisory group again. I love the simplicity of the terms of reference that have been developed, and I understand that part of the role is around ongoing accountability to ensure that every possible way of engaging with the community and staff and all stakeholders has been tried, but also just assurance that they are then, as you go through to develop options, that they will be able to comment on the options appraisal. Now, I'm pretty certain that's written into the terms of reference, but I think it's important that they see the whole process through.
Thank you, Greg. So in terms of your first point, you're absolutely right. We recognise it's really challenging to engage with something that talks about, the future strategic direction of health and care. On the positive side, in terms of our online questionnaire, we've had well over 1,000 responses so far to individual questionnaires. So it's given us a whole wealth of information as well as the focus groups. But again, as we move through the months of the programme, we're keeping that door open. We'll have to stop at a certain point, so we'll need to consolidate all our learning and bring it all together. But we have a continuous engagement process that will kind of go like a circle throughout that whole linear process that I described earlier in the presentation. I think in terms of the EPAG, that it's the engagement process advisory group. It is set up specifically for advising on the process, but we're looking at how we can develop that group to then look at the options and how we can bring them in. We've got to be clear about how we demarcate between those that are part of the process and those that contribute to the process, so we're not marking our own homework a little bit as well. But I think those comments that you've made will be well received by the work stream leads within comms and engagement. So I'll definitely take that back.
Thank you very much.
Okay, Dr. Bisaria.
Yeah, thank you, Susie, for a very helpful and informative presentation. It was just a comment really regarding there is the challenge of getting clinicians involved, but I just wanted to make the point that certainly within West Lancashire, it's been very well advertised in our newsletters with our colleagues. The online option of being able to review the involvement and the pathways is there. And also presentations have been given to primary care colleagues on video meetings too, even this week. So even though clinicians may not be actively involved, they are aware of the opportunities and how to access them. And I think in this week's meeting, they were also told, you can get involved at any point. So although it has been challenging and it continues to, the awareness is there amongst primary care, which I think is reassuring.
Thanks, Dr. Bisaria, and that's obviously really good to hear. I mean, I guess I am conscious that the one item that we've been asked to consider and give feedback on is around clinical engagement. So is that an area that anybody has any helpful suggestions or anything that we can do as a joint committee to improve the level of clinical engagement that the project is able to achieve at the moment? Fiona?
I don't think there's an easy answer, Helen, because if there had been, I think we would have found it. And I know some of the work that Rob and I'm sure Diraj and other clinicians have been involved in trying to get use of digital technology to try and do that engagement. So Susie's got, a more rounded flavour. And I think we just got to come at it from every angle. Obviously with the pandemic, potentially, the infections in Sefton have not diminished. We've got to just make sure that our clinical staff, I think as Susie said, who are tired, have got the space to be able to deliver on acute care and general practice and social care and everywhere. So I don't think there's an easy solution. And I think my understanding from Susie, Rob particularly, sorry Diraj, just because Rob's on the Southport side, is that where they can, they're using innovative ideas and making sure that engagement happens. I don't know, Rob, whether you just want to sort of give some examples to give us some assurance that we're doing all we can as best we can.
Yeah, no, I think I'd agree. It is just really difficult because nobody that kind of isn't part of CCG or doesn't have kind of time carved out and funded has any time to be involved with anything. So we've been using things like SharePoint and sending that around. Now, I think you can see who's accessed that. So in terms of assurance, we can kind of see how many times that's been clicked and how much. And then, similar to West Lancs, as Diraj was saying, it's being publicised where we can in GP meetings. The specific question, what else we can do, I don't know is the honest answer. I think we're probably doing what we can given the situation, and the situation is not going to get any better.
Okay. I'm sorry to not be able to provide anything more specific, Susie. I have to say it's very good to know that, if you like, innovative ways of trying to involve people are being used rather than just the standard methods that might have been used in the past. But I'm not sure, beyond what's been said, that we've got any magic wands to try and help improve the situation. I guess it's just a matter of continuing and doing the very best that can be done. And I guess from a sort of a lay perspective, it is reassuring that there are those checkpoints with the external clinical senates coming in and doing specific pieces of work that I guess from our assurance perspective should mean that the models of care that are being developed, if you like, are sound and address the questions that are that are being asked of clinicians in terms of the appropriateness of the changes that are being proposed. So I guess from an assurance point of view, it does mean that we have got that, we've got those specific checkpoints, but it's obviously unfortunate that we're just at a stage with the pandemic that it is so difficult to get more clinicians involved in the process. I don't know whether anybody else has got anything that they want to add. Jackie, sorry.
No, it's okay, Helen. I think one of the things we're trying to do now is not just get clinicians into Shaping Care Together meetings, but actually trying to take Shaping Care Together out. So as Diraj said, we've been to West Lancs GPs this week. We're trying to get to where actually clinicians are and do it a different way. We have talked about maybe going into business units in the hospital so that, again, we can get round all of the different departments. I'm not sure whether that's come to fruition yet, but it's to try and do that as well, Helen. And I suppose the other thing I suppose I wanted to say was, if we get approval, Susie, through NHSEI at the end of this, we go forward into a consultation stage, don't we? We may go forward in. Again, there will be an opportunity again. Maybe, Helen, we might be in a better position, not as much in it that we're actually clinicians. Maybe has a bit more time to have some input into this. So it's not that we are sunk if we haven't got, you know, everything that we need to do now.
Thanks, Jackie. That's a good point. Susie.
Thank you. So it's been really helpful, and I wasn't expecting a magical answer, I suppose, today, because I just completely recognise it's a tricky issue. But I just want to give the Joint Committee an assurance that this is absolutely a clinically led process, and we will work as tirelessly to get as much clinical voice into this as possible as we move forward, as well as the patient and public voice. It's all really, really important. So it's just to kind of give the assurance this is not a management-led process, this is a clinical-led process, and we won't move forward without that kind of clinical body behind us in terms of what we need to do for our next steps.
Thanks, Susie. Anything else from anybody for Susie on the project report? Okay, I'm conscious that Susie was asking for, I don't know whether approval is too strong a word, but review, and I think you did use the word approval of the hurdle criteria. I am conscious that unfortunately Fiona Taylor has had to leave us, so we aren't actually quorate anymore, but we can with your permission consult with Fiona after the meeting to get her approval or otherwise for the hurdle criteria. Is everybody else that's on the call happy with the hurdle criteria as they stand? Do you want more information on them? Do you want to have an opportunity to think about it? Where are people on the hurdle criteria? Any comments from anybody? Jackie.
I was just because I think they seem we've thought about this before, I think, and we've come up with things that didn't seem acceptable. For me, these seem quite broad, broad and yet hurdles that we would need to get over. So for me, they're quite they're relevant. They are the things that we need to consider. So I'd be happy with those.
Okay. Do I take silence as golden? Do I assume that because I'm not hearing from anybody else that everybody, I'll come to you in a second, Greg. Is everybody else happy with the hurdle criteria as they stand? Okay, I'll come to you, Greg.
Yes, thanks, Chair. I was just going to say that obviously in some ways it relates to this continuous process that's been going on for this committee and for the other groups like the Comms and Engagement Group. And so it's work that we have been working towards and we have been reviewing on a regular basis. And as an example, we've paid lots of attention to the importance of the degree of community involvement, survey take-up, focus groups and everything else. And so, you know, I'm very pleased from my perspective that that has been taken into account and will be taken into account. And in fact, we can show through prior meetings that we've moved forward and we've made changes with the help of community members through the focus groups, CVSs have been mentioned, and Healthwatch. And we can see the results in the growing engagement around the process. So I'm pleased with that process and development and close monitoring of it. I think everybody's looking very hard at each aspect of it.
Okay, thank you, Greg. So I take it then that everybody is content with the hurdle criteria. I'm content with the hurdle criteria. So is everybody happy that I seek the agreement to those criteria with Fiona outside the meeting, taking chair's action to approve those criteria? Okay, so that's how we'll just finalise that. Okay. Does anybody have any other business? Okay. In which case, the date and time of our next meeting, we have got a development session on Thursday, the 26th of August at 4 o'clock. And our next meeting in public is on Thursday, the 28th of October, also at 4 o'clock. So look forward to seeing everybody then. Thanks very much indeed.
Thanks, Helen.
Thank you.
Thank you.
Thanks, Helen. Bye, everyone.